Um, the first distinction that I want to make, the first thing that I want you to think about, and one of the things, so Edmund talks about my CV. I publish a lot and I review a lot and I present a lot. What that means, I'm having a lot of dialogue with people. And in particular, when we publish papers, I hear back from reviewers and editors that they may not understand the message and what we're trying to say. And this is we're going to start with one of the ones that's tricky. And that is the difference between pathophysiology, which is measurable disease or impairment. So for idiopathic median neuropathy at the carpal tunnel, that would be reduced nerve conduction velocity, a prolonged distal and motor sensory latency. It could be electromyographic abnormalities reflective of denervation. Those are objective, those are measurable, verifiable events. It's sort of like true science, like you could measure the stars or subatomic particles in a collider. These are experiments you can do, and you can make measurements. Illness is discomfort and incapability. Illness is the state of being unwell. It's entirely subjective. It can't be proved or disproved. It is a person's truth. They experience it, and it is real. Now, the thing to notice is there is a discordance between measurable pathophysiology or idiopathic median neuropathy at the carpal tunnel. So I'm excluding rheumatoid arthritis, maybe somebody has severe hypothyroid, distal radius fracture. I'm focusing on the idiopathic variety, the variety in a healthy person. Person gets knee neuropathy through no fault of their own, and it's measurable. And then carpal tunnel syndrome is the symptoms and signs that are characteristic of that median neuropathy. But you can have relatively notable illness and limited pathophysiology. Now, the discordance is often explained by mindset and circumstance factors. And one of the more obvious ones is if you're feeling despair or if you're feeling down. And so if the DASH score is a measure of discomfort and incapability, the more symptoms of depression, the more despairing you are feeling, the more symptoms and incapability you feel. So this is an example of the discordance between the experience of illness and the measurable pathophysiology. And what we've noticed over the years is that even more so than feelings of worry or despair is unhelpful thoughts and unhelpful feelings. So kind of ruminating or getting stuck on the symptoms and or misinterpreting them, like for instance, interpreting an activity that causes a symptom as an activity that's causing the disease, and therefore you limit yourself and avoid activities. So these have very strong correspondence with illness. Again, here's the DASH, disabilities of the arm, shoulder, and hands. That's symptoms and that's discomfort and incapability related in the arm and hand. And you can see the different lines are levels of catastrophic or unhelpful thinking, misinterpretation of symptoms. And these in the categories low, mean, and high are fracture severity. This comes from a study done in Oxford of over 700 people with a broken arm. And you can see that a low fracture, like a non-displaced distal radius fracture, radial head fracture, can have just as much impact or illness or discomfort and capability as a high fracture with average type of thinking. If you have more unhelpful thinking, you experience more illness. And this is getting more and more sophisticated, where we can actually identify statistical patterns where if you're feeling greater kinesiophobia, worst case thinking, depression or anxiety, you experience more illness. And I don't have a slide for this, but we've done some work with electrodiagnostic parameters, and they don't really even show up. So the severity of the measurable neuropathology does not correlate as strongly as one would expect with the neuropathology. And amongst these people recovering from fracture, you can see that the people who are experiencing more distress and unhelpful thinking don't recover. They start worse and end worse, and they never fully recover from their injury. So this is what we experience as doctors every day. We get to experience this difference between disease and illness. And here's a patient who I saw who had severe tendon atrophy, but this person was not seeing me for carpal tunnel syndrome. They were seeing me for something else. So they have very severe idiopathic median neuropathy at the carpal tunnel, and it's measurable in terms of atrophy, and yet they are not experiencing much illness from it. So let me take a break there. And if anyone has something they want to put in the chat, but Edvin, let me put you on the spot. So I'm drawing a distinction between measurable median neuropathy and discomfort and incapability in the context or related to median neuropathy. Does that make sense, or what gives you pause about that?
Yeah, I understand that if the patient has pain or numbness, it makes him discomfortable, so he feels the illness. Yeah, we get the point.
Yeah, and that's a good way to think about it. So I would say that pain is not a symptom of carpal tunnel syndrome. Pain is not a symptom of idiopathic median neuropathy of the carpal tunnel. Paresthesia is the symptom, is the hallmark symptom. And people will often report paresthesia or describe it in terms of pain, because intense paresthesias are uncomfortable. And so what our job is to make sure that what they're experiencing is actually paresthesia, because if it's not paresthesia, then the diagnosis is probably not median neuropathy.
Yeah, which is subjective phenomenon.
Right. So I think that's an area of a lot of debate, right? So some people believe that you can have important levels of median neuropathy without any measurable median neuropathy on nerve conduction. Some people believe that you can offer surgery to a person who is having symptoms, even though you can't measure any disease. And I think that's an area of debate. So I'm not going to resolve that debate, but I'm going to point out one of the reasons that debate exists. Okay, so the next concept I want to address is the difference between, I see a question. Let me see if I can. Do you often observe spontaneous recovery even in severe cases? Great question. I would say that if you get to the point of loss of sensibility and atrophy, those are permanent changes. It might improve somewhat, but it will never improve completely. And that's an important, we're going to get to that later, but that's an important thing to understand, because if you don't understand that, and the patients often definitely don't understand that, right? They think that when you do surgery or a shot or whatever, even a splint, if you do something for a patient, they're going to expect that will cure the problem. It's not it's a normal expectation. I'm going for treatment. I want the treatment to fix this. The doctor's treating me. It will fix this. And we have to make it clear that it will not fix it. And that is difficult to do. I just published a paper on people who struggled after surgery, and it was mostly anxiety, but it's also partly the severe disease, because the surgery doesn't fix that. Okay, so that's a good segue into disease modifying versus palliative treatment. Again, terms that you may not be familiar with, that you may not use every day, but I hope after this talk you will. And disease modifying treatment alters the course of a disease compared to if it was untreated. And palliative treatment just alleviates symptoms, so it doesn't actually change the course of the disease. So let's get a look at what that looks like. So I'm going to give you an example of disease modifying treatment. This is a polio ward before polio vaccination, right? So polio vaccination alters the course of the disease. And in fact, it makes it so that people can be exposed to poliovirus and not suffer any untoward consequences. That's a disease modifying treatment. Vaccination is a disease modifying treatment. Here's another example of a disease-modifying treatment. And what blue is the incidence of chronic myeloid leukemia, and red is dying from it. And you notice in the 1990s, right around 2000, late 1990s, 2000, all of a sudden people aren't dying as much from it. And that's Gleevec, or a very powerful, useful, targeted chemotherapeutic agent, which dramatically transformed the ability to cure people with that problem. Now let's look at lung cancer. Okay, the incidence of lung cancer is decreasing, but the mortality and metastatic incidence is not. So what is this telling us? This is telling us that we don't have any disease-modifying treatments. Public health works. If you get people to stop smoking, that's the curve going down. People stop smoking. Public health or exposures make a difference, but treatment is useless. So that there is no disease-modifying treatment of lung cancer. And then one more, this is thyroid cancer. So here we're diagnosing more thyroid cancer, but people are dying and getting metastasis at the same rate. This is overdiagnosis. This is what overdiagnosis looks like. So not only are you don't have a disease-modifying treatment, or you don't even need one, because the natural course of the disease, the natural history of the disease is benign. So you're better off not knowing if you have a thyroid carcinoma in most cases. Some people have trouble with it, that small line at the bottom, but for the most part, it's something that you'd rather not, you don't need to know about, you don't benefit from knowing about your whole life. So this is a way to think about, disease modifying versus palliative. So for idiopathic median neuropathy at the carpal tunnel, what are the disease modifying treatments? What are the ways to avoid this atrophy? What are the ways to change the natural course of the disease? I welcome anyone's chat, but Edvin, I'm going to put you on the spot again. What are the disease-modifying treatments of idiopathic median neuropathy at the carpal tunnel?
Wow, it's a tough question.
And one that we could debate, right? There's room for debate, right?
Yeah, so we are not talking for surgery, right? We're talking for conservative.
Surgery is disease-modifying. Do we agree? If I operate on moderate carpal tunnel, no atrophy will occur.
Yeah, so surgery.
So
one of the options is surgery.
Surgery is disease modifying. What else?
Yeah. So one of the participants is saying decompression. Okay, we're talking about
surgery
decompression.
For sure. Yeah, surgery for sure. Like any kind of decompression. People are doing it with scopes and ultrasound guided and all kinds of new technology. Careful with that stuff. I think open is so simple, and you got to keep the nerves safe. But it's out there. So yeah, decompression, cutting the transverse carpal ligament. Anything else?
Yeah. So what about the distal nerve blocks?
Or like losing weight? Yeah, maybe. I'm not sure there's any evidence for losing weight, but BMI is associated with carpal tunnel syndrome. The tricky part there is it symptoms and signs, or is it neurological abnormalities? I've seen some evidence that it actually is associated with neurological abnormalities. So losing weight might be disease modifying, could be.
Yeah. So
and then you're asking about steroids. Yeah. Well, and then activity related.
Yeah.
Slightly. The best data I've seen is that it's very almost negligibly associated. So it's mostly genetic. Wrist splint. So wrist splint is palliative. I don't think there's any evidence that wrist splint changes the course of the neuropathy. I don't think activities, again, the relationship between activity and idiopathic median neuropathy at the carpal tunnel is small and almost negligible, so I don't think that would make a difference. Corticosteroid injections, the evidence shows that there can be a transient and unpredictable improvement in nerve conduction velocity, but it's transient. So it probably is more palliative and doesn't change the natural course of the disease. So I think we're pretty much at surgery. Surgery is the one. And if you think about the things that we do, like me as an orthopedic surgeon, A lot of what I do is more palliative, like a joint replacement is a palliative type of salvage surgery, or arthrodesis. It's palliative. I'm not giving them their joint back. I'm taking their joint away and giving them something else. So most of what we do is not disease modifying, but this is one that is disease modifying, which is very rewarding. I mean, disease modifying treatments are fun. Okay, so we've already kind of addressed, or happened into this one. Does activity modify the natural course of the disease? And I've made the argument that it probably does not. So we'll skip to the next one, and we can get into something. Again, I'm not going to resolve the sources of debate. I'm just going to help us understand why we debate and why there's room for debate. And the next on the list is non-specific versus specific effects of treatment. And what I mean by that is that you can do a treatment to somebody and they get better independent of anything the treatment does to address pathophysiology. And you think about what that means. I do something to you, you feel better, but it doesn't have anything to do with treatment of the pathophysiology. So think of like placebo effects might come to mind, where if I give you a sugar pill, you feel better. There's also regression to the mean. There's the self-limiting course of many illnesses. And that's as opposed to specific effects. If I release your transverse carpal ligament, you no longer wake up with numbness and tingling at night. Your nerve conduction velocity improves over the next couple of years. So those are specific. I can improve the pathophysiology, and that improves your symptoms. That's a specific treatment. I pretend to cut your carpal tunnel. I do placebo surgery. You feel better. That's non-specific. And when we see this is an orthopedic example of pretending to do knee arthroscopy to take out part of the meniscus in somebody with arthritis. And what has been shown is that it is all non-specific effects. There are no specific effects. The people do just as well if you take out some of the meniscus as if you don't, and you just pretend to, and they believe you've taken some out. So those are the and placebo effects are meaning and context effects. It has to do with beliefs and mindsets. And in fact, you can measure them, and you can block them. You can block them if you use, like, for instance, naloxone to block endogenous opioids, it blocks the placebo effect. There are other neurotransmitters that are involved, and you can also block placebo effects. I saw a chat about what's the point of non-operative treatment. Non-operative treatment is palliative. So if you're waking up at night and you wear a splint, you won't wake up at night. You can go years without having surgery. So palliative treatment is still useful, but you have to keep in mind, like, if you gave somebody a splint or a steroid injection and they said, I feel better, they're not done yet. They still have a narrow tunnel that they were born with, and you don't want them to come back in 5 or 10 years with atrophy. So you got to make sure that they know that that's a palliative treatment and that the disease will keep marching on, and they want to catch it before it causes permanent harm. Thank you for those comments. I really appreciate the interactiveness. Okay, so this is what non-specific effects look like. We're looking for the drug or surgery effect. We're looking for the specific, but every treatment has both non-specific and specific effects. There are psychological processes, like I mentioned, the biological mechanisms, endorphins, dopamine, serotonin. Then there's social and contextual factors that create belief and the sense of care that actually heal you. And so what we want to do is we want to make sure our treatments are doing more than that. Knee arthroscopy for arthritis doesn't, so we shouldn't do that treatment. So what about for those of you who operate on unmeasurable median neuropathy? Nerve test is normal, and you go ahead and operate. Now, how do you know that the benefit derived, thank you, doctor, I feel better, how do you know that that isn't just non-specific? And so the way we would need to do that would be, again, a placebo-controlled trial. The only way you can do look for specific effects with subjective outcomes is to do sham surgery controlled trials, which are ethical because we do want to be sure that what we're offering is not just false hope. So that's a pretty good provocation. I think I'll leave that one hanging. I'll get to the next one. Well, I got a chat. Let's see what we got. So, when does the surgeon medical legal responsibility start? Well, it's interesting. I mean, I'm in the United States. We're the capital of suing one another. With a doctor-patient relationship is where the medical legal. If I have a doctor-patient relationship and I misdiagnose you, then I could be liable. So it starts right up front. But I think part of malpractice is causing permanent harm, and so that's usually going to be the form of a harmful treatment. Usually, not so much in the diagnostic realm here. Okay, so next point is, as I mentioned before, we've already talked about this, that the way our brains work, the way our minds function is imperfect. We are guessing, interpreting machines. The human mind is it's always interpreting, and it often gets things wrong. Let's look at that a little bit. So here's an example of what I mean. So if you look at the top arrows, the top lines, the middle one looks longer. And I like to use this as an example of your autopilot interpreting mind, or what Kahneman and Tversky, who won a Nobel Prize for their work on cognitive processes, have called type 1 or system 1 thinking. It's your automatic interpreting, guessing part of your brain, which is very useful. I'm pointing out a situation where it's erroneous, it gets it wrong. But a lot of times it gets it right, like facial recognition, or 2 times 2, 4 pops into your mind without any effort. So the autopilot part of your mind is very useful, very powerful, very accurate, but it's more erroneous and error prone than the analytical part of your mind, which is system 2, the critical thinking part of your mind. And so what you want to do is be ready for your autopilot interpreting mind to get things wrong, and create systems to catch those errors before they cause harm. So here we can measure the length of the lines, and by measuring the length of the lines, we know that that they are the same length. And for those of you who are interested in this, you can look up this book or some of the lectures and YouTube videos online. And they won their Nobel Prize in economics, but I think it applies to everything we do, and it certainly applies to health, and it applies to medicine, and I think it applies to ethics. And I'll direct you to a site called Ethics Unwrapped. It's based at University of Texas in Austin. It's a homegrown thing in my university. Lots of great videos, case studies, definitions, and then this book accompanies it. Cara Biasucci and Robert Prentice put together Ethics Unwrapped, but they point out how the autopilot interpreting part of the human mind actually creates, it's what makes good people do unethical things, have ethical lapses. None of us have ever been perfectly ethical, and the reason is because of the way your mind works. And I think if we apply that to our work as surgeons, we do checklists like pilots do, because no matter how experienced and intelligent you are, you could make any kind of number of mistakes and do the wrong procedure. And I've published on my wrong procedure in the New England Journal of Medicine, amongst many other errors. And I'm going to go back to I had a request to go back to this. Thinking fast and slow is fast is type 1 and slow is type 2 or critical thinking. And then behavioral ethics in practice, why we sometimes make the wrong decisions. So we have adopted safety systems like pilots do, because we know that being intelligent and experienced and trained is not enough to avoid slips, because our mind is guessing and interpreting. We will always make mistakes. So what is it that our patients are going to misinterpret? We talked about paresthesia and pain. That is we have to make sure that when somebody says that their symptom is pain, that it is painful paresthesias. If it's just pain, the diagnosis is almost certainly not most importantly, median neuropathy at the carpal tunnel. Somebody may have a source of pain and occasional paresthesias, and they might have two diagnoses, but if they mostly have pain, then the problem is not idiopathic median neuropathy of the carpal tunnel. The hallmark symptom is paresthesia. So make sure we get that right. Other misconceptions could be that this came from typing, I need to stop typing. This came from my work, I need to stop my work. Those are very common misconceptions. Here's a common one. I mentioned this person who I was seeing for something else didn't even know that they had severe median neuropathy at the carpal tunnel. So a lot of times people show up and they say, I've got this new problem, it just started, but it's actually not new, it's newly perceived. And that's a form of misconception. Now, understanding that is important because you have to be able to counsel them that they have some permanent neuropathy, and you want to give them hope, and the hope that the room for hope, even though you can't fix the problem of diminished sensibility and weakness of palmar abduction, you can't make that better. You can maybe make it a little better, but you can't make it all better. But there's a lot of reason for hope because people have been living with this for decades and not even noticing it. So they've proved that they can accommodate this, and they will accommodate it. But that's not the way people are thinking when they come and they think this is new, you have to fix this. My only hope is that you fix this. So misconceptions, expect them, anticipate them. I saw in the chat a question about, whoops, let me go back to the chat, about can you decide surgical treatment without EMG? So if I show you this, person again, I think the diagnosis of idiopathic median neuropathy at the carpal tunnel is pretty clear here without a nerve test. So, and if you use the, there's this thing called the CTS6, which is essentially a probability generator. And so if people are waking with paresthesias and immediate nerve distribution, nighttime symptoms, weakness of palmar abduction, atrophy, diminished sensibility. So if they have enough of these things, the probability is very high, even without nerve studies. But when it gets down to mild or moderate median neuropathy of the carpal tunnel, you don't have atrophy, you don't have lost sensibility, you don't have weakness of palmar abduction. It gets harder to distinguish normal from abnormal. And even nerve tests can't do that well because there's a continuum of nerve pathology. I resolve that by just I don't find the need to operate on mild median neuropathy of the carpal tunnel, because mild or very mild or undetectable median neuropathy, if we can agree that that might exist, is something that people accommodate well. So I work on accommodation, and then when it gets to moderate and the brace is not alleviating symptoms, then I operate. So that's how I do it. I think each of you has a way of processing all these things that I'm pointing out. So a common misconception is that that carpal tunnel syndrome and median neuropathy is caused by activity. There's evidence from a large population-based study in Sweden that typing and a lot of computer work is, if anything, protective. So by correcting or reorienting this misconception, you liberate people to do any activity that they want. Another common misconception is that when the symptoms are alleviated, that the problem is gone. I mentioned this before. So by correcting and reorienting this misconception, you have to help people understand that without making their transverse carpal ligament longer and their carpal tunnel bigger, until we've done that, then the median neuropathy is likely to progress very, very slowly and could permanently damage their nerve. So these are important misconceptions to anticipate and manage. And here's another one that we already mentioned, that persistent symptoms, newly appreciated, are often misinterpreted as recurrence. So when I meet somebody who thinks their carpal tunnel syndrome is back, the first thing I want to know is, did they have diminished sensibility prior to the other surgery? Or did their nerve test show severe neuropathy? And if either of those things is true, either symptoms and signs of severe neuropathy or electrodiagnostic evidence of neuropathy, then almost certainly this is not recurrence, but rather persistence. And they've just noticed, newly noticed the symptoms that were already there in the background. And I would posit that persistent, newly appreciated persistent symptoms are common, and recurrent carpal tunnel syndrome after successful release of the transverse carpal ligament is almost unheard of. You have to get rheumatoid arthritis or get some other disease for that to happen, a space-occupying lesion. So that's the way I process the data on misconceptions, is that I should be very careful diagnosing recurrent carpal tunnel syndrome. All right, I didn't anticipate, although I'm not surprised, that we've already had a chance to discuss some of the things I wanted to pause for discussion. So I'll go ahead and keep going and finish off, and then we can open up for discussion. The way that I process all of these principles that I've shown you, that there is a difference between pathophysiology and illness, that people experience greater illness based on mindset and circumstances, that mindset and circumstances are often unhealthy because of the way that our autopilot mind kind of prepares for the worst and tends to misinterpret bodily sensations. So we can expect people to have ways of thinking about their body that could be healthier, and we can work on those. We can focus on paresthesia, not pain. We can focus on surgery for moderate median neuropathy rather than independent of the symptom level, and we can help people accommodate, knowing that accommodation is a very effective health strategy. If they understand their body, if they're given the tools to manage, like night splints, most people will be able to accommodate mild and very mild and unmeasurable disease very well. And if they're not accommodating well, then we need to think about the issues I showed you at the beginning of the talk: misconceptions, despair, and anxiety. And these are things that are tricky to address. Surgeons are not well trained in this. We tend to be pretty blunt and matter of fact and goal oriented. I am not naturally a good communicator, but having recognized the importance of effective communication, I've worked very hard to become a better and more effective communicator. And I would recommend, for the joy of your practice and the joy of your patients, that it's as hard as surgery, if not harder. And working on effective communication strategies, I'm going to recommend to you. Here's a few tips. Prioritize the relationship and trust building over the medicine. The medicine will work itself out. We'll always have room to take care of the neuropathy and plan out what we want to do. Craft your information to be brief and to cultivate a healthy mindset, to reorient those expected misinterpretations and misconceptions, and find ways to depersonalize difficult discussions, such as that surgery is the only disease-modifying treatment, and that there is permanent nerve damage when you have severe median neuropathy. These are difficult discussions, so find ways to depersonalize them. Here's a link to something I work on at the Center for Health Communication related to effective communication strategies. So with that, I will stop sharing and we can go into some discussion. I noticed that in my practice, I have people who have symptoms that are consistent with carpal tunnel syndrome. So by that, I'm going to assume paresthesia, right? Not pain, but paresthesia, and normal nerve test. And they notice it mostly at night. Okay, I agree that exists. That is, if you can't measure the neuropathy, then that is by definition very, very mild median neuropathy. And I would say, in my opinion, and from my perspective, the treatment of very, very mild median neuropathy is non-operative. It's night splinting, it's reorienting misconceptions, helping people understand their body, alleviating concerns and worries. It is not surgery. And I think we only would think about surgery for unmeasurable nerve pathology if somebody was feeling very desperate, lost, hopeless. And so keep that in mind. If you're seeing somebody who has a lot of symptoms, a lot of discomfort and incapability, and no measurable meaning neuropathy, make sure you take care of the whole person, because that's probably a key issue.
There is a question from Yunus Aydın again for reflex sympathetic dystrophy. So
yeah.
what do you think?
Okay. So, yeah. So that's okay. There's a group of us who are asking the world, both clinicians and patients, to rethink the idea of reflex sympathetic dystrophy or complex regional pain syndrome. If we, so the idea behind that diagnosis is that eventually we will find a pathophysiology, right? Right now it's characterized by 4 criteria of symptoms and signs, but there is no identifiable pathophysiology and there is no treatable pathophysiology. And the hope is that one day we'll find, like when I was a teenager, there was peptic ulcer disease, and the cause of peptic ulcer disease, stomach ulcers, and was stress. And then a couple of Australian guys discovered H. pylori, swallowed it, gave themselves an ulcer, did a bunch of experiments, and proved that ulcers are actually caused by bacteria and they're cured with antibiotics. So that's what we're looking for when we talk about reflex sympathetic dystrophy or complex regional pain syndrome. But we're not there yet. We don't have the H. pylori. We don't have the pathophysiology. Now, what we do have is disproportionate pain intensity, discomfort, and disproportionate limitations. So somebody who's afraid to use their hand. That happens all the time. If you see somebody who sprains their finger, in my world as a hand surgeon, somebody sprains their finger or is recovering from a broken wrist, they'll get stiff fingers if they feel like painful activity is harmful. And so for you all, if you operate on the carpal tunnel, you do release carpal tunnel, causes bruising and bleeding, and then it hurts to make a fist. If they interpret that pain as harm, which is a natural association, it's an automatic thought, then they are liable to get stiff. And if they don't move their hand, not only do they get stiff, but they get swollen, and the skin looks different, all those changes that are characteristic of complex regional pain syndrome. Now, one of the criteria for the diagnosis of complex regional pain syndrome, criterion 4, is that there isn't a better explanation for criteria 1, 2, and 3. But that never is the case. People have pointed out that the criteria for complex regional pain syndrome are internally inconsistent, because if you have surgery and don't move your hand, you get 1, 2, and 3. If you break your wrist and don't move your hand, you get 1, 2, and 3. So there's always a better explanation for what's going on, and it is disuse or avoidance of activity. That's the explanation.
There is another question from Ismail Akkor. He's from İzmir, neurosurgeon. His question is, what can be said about diabetic patients?
One of the things, a couple things about diabetic patients. So if there's advanced diabetes, they'll often ascribe their finger tingling to the diabetes, and particularly if they've already got neuropathy in their feet. And what happens with that is they then neglect the carpal tunnel and end up with permanent nerve damage. Another example of where that happens is people are diagnosed with a neck issue. They ascribe all their tingling feelings to that, and then they show up with atrophy. So I think it's important for, if the more we focus on paresthesia, eliciting paresthesia with Tunnel, Durkan, Thalen, if we can localize it, and then if it's unclear, measure the neuropathology, then we can identify, even in the diabetic patient, whether they could benefit from carpal tunnel release. I think it's plausible that if you have both diabetic neuropathy and idiopathic median neuropathy at the carpal tunnel, that the results of the surgery will be less satisfying. And people who have advanced diabetes also are more likely to split their wounds open or get minor infections. But if the wound is open, it will always heal in, just takes longer to heal. And an open wound is almost never an infected wound. So it's just a matter of dressing the wound while it heals. So those are some thoughts about diabetic patients.
And there is another question from Ayman Hassan. What is the most sensitive test for carpal tunnel syndrome? Is it nerve conduction velocity?
Yeah, so this is the thing that we just published a study recently, in the last year or two, where we took all the people that were referred to get nerve testing, and we looked at the, essentially mild and very mild nerve pathology. It's really hard to draw a line. It's very hard to draw that line. And keep in mind that if you do a nerve test, people do it at different temperatures, they use different machines, they have different spacing between the electrodes, and all of that can create some variation in the numbers. So what I look at is, I think the way forward, in my opinion, is that any nerve pathology, whether it's based on exam or based on nerve testing, that is mild, that's close to normal, is something that we should not operate on. That's a non-operative treatment. And typically when people show up and it's time for surgery, they're at the moderate stage, and that's usually very detectable on examination. So I limit my surgical indication to moderate idiopathic median neuropathy of the carpal tunnel with reproducible symptoms and signs. I almost never get nerve tests unless it's a confusing situation. And I stay away from uncharacteristic symptoms and what I think might be mild neuropathy. And that's been a useful way to practice. I also tend to diagnose when I notice people doing worse than I'm expecting them to do, when they're having a lot of discomfort and incapability. I connect with them on a human level, try to understand what concerns they're facing, what sources of stress and distress they have in their life.
And there is a question from Yunus Aydın. Fallen test, is it worth for you? And maybe you can give us opinion for Tinel test, Tinel sign.
Yeah, I think they're all useful, right? There's none of them are perfectly sensitive and specific. What happens, I learned this from Dr. Gelberman when I was a resident, is that there's a point at which the neuropathy kind of cools down. So once it gets pretty severe, they may not have a Tinel any longer. They may not have a Durkheim sign or carpal compression test. They may not have a positive Phelan, because it's gotten so far that they have permanent loss of sensibility, and those tests may be less helpful. But earlier on, they're usually pretty useful tests, and one or more of those is usually positive in somebody who's got more than a little median neuropathy at the carpal tunnel. I think it's usually possible to make the diagnosis of median neuropathy without a nerve test.
And there's a question from Ismail Shafa. How do you follow up your operated patients, EMG or just clinic?
Yeah, this is interesting. So 60% of my patients in my current setting are covered by a type of government insurance that is regional. So for us, it's county. The county pays for poor people to have coverage. And we've set up a payment system where I am paid to take care of carpal tunnel syndrome for a year. So if they come see me, a new patient, I get here's the money, take care of carpal tunnel syndrome. Now, it turns out with poor people, more than half the people, because they have lack of access, by the time they get to me, at least half of them are ready for surgery. They either have moderate to severe or severe carpal tunnel, and so half the people I do surgery on. Now, the way to make money in this contained system where I've got a certain number of dollars they're paying me is to be thoughtful about tests and treatments. So I don't do nerve tests, so I save that money. I don't do steroid shots because they're palliative and not disease modifying. I use splints, those are inexpensive. And I do the surgery in the office under local. And I use epinephrine so that I don't need a tourniquet or sedation. So, and then afterwards, I do a phone call or video visit at 2 weeks. I call them the next day and I do a phone call or video visit at 2 weeks, and then they see me if they have trouble. So there's very little, there's as much postoperative contact as they want, but most people don't want much contact.
Okay, thank you, sir. And can you give your opinion on endoscopic or open surgery, Con and Pro?
Like I said before, I think anything that safely releases the transverse carpal ligament will do the job. If I think about what it takes to do an endoscopic release, there's a lot more equipment and money involved. Usually, that's probably would be hard to do in the office. I know some people have tried to develop endoscopic for office. I know people have started to do it under straight local, but most people still use anesthesia. So the resource utilization with endoscopic is much higher. So it's more costly, and it takes more time. And so there's more time in the operating room. In most of our hands, I'm sure some people can do it quicker and maybe save time on stitching. So I personally have not made use of it. And also, there is a higher risk of nerve injury, mainly while you're learning the technique. I agree with that. And if you know when to bail out when you can't see. But because of that, I never made it part of my surgical techniques.
And another question from Yunus Aydın, do you apply immobilization after surgery?
This is something I think we can say is very evidence-based, is that there is no need for immobilization. If people want to do it for comfort, that's fine, but there's no benefit to immobilization. There's no benefit to formal hand or occupational therapy. There's a lot of things that are clearly of no benefit.
And I have a question. Do you cut the antebrachial fascia during the surgery?
I just make sure, for me, I want to get to the point where I can spread with the scissors and it rips apart. Then I know that I'm in the antebrachial fascia, not the transverse carpal ligament. So as long as it doesn't spread, I feel like I need to keep cutting. But once it spreads easily with my scissors, then I know that I'm tearing fascia and I'm out. I've released the entire ligament.
Thank you, sir. So I don't see more questions.
That could be a good place to stop. That was good, though. Those were really good questions.
Yeah. So, okay, we can wait 1 minute to see. So
there's another one. How do you close the skin? Yeah, so I use epinephrine. I don't know if you all are aware of. It was really popularized by a Canadian guy named Don Lalonde, who's a plastic surgeon, and Don is in Nova Scotia in Canada, where there's no private practice. There's no private practice in Canada, so he can't set up a surgery center. His options for surgery were his office or the hospital. And the hospital was so inefficient for small cases that he really wanted to do as much as he could in the office. So he set about studying whether it was safe to use epinephrine in the fingers. And he looked at what the issue was in the past, and then figured out that it was probably safe. Talked with other people who were doing research, and then started to carefully try it. And so now he uses epinephrine routinely and can do things like tendon transfers, Dupuytren contracture release. And I and others have adopted those techniques. If we use epinephrine and we give the injection 30 minutes before the surgery, or at least 5 or 10, but 30 is better, then there's very little bleeding and no need for a tourniquet. So that's how we manage the bleeding. And then I also picked up a technique that he's popularized for skin closure. We started doing this during the pandemic so people wouldn't have to come back in and be exposed potentially to COVID. We started doing buried absorbable sutures. And I use, well, I think that's all you need to know. I use a monofilament 5-0 absorbable suture, and it's been fine compared to nylon. And we've used chromic as well. We've published on that. They're about equal. It's a little bit easier with the buried, because people don't, they make it a little reaction or a tender area. That's the downside, but the wound heals up pretty quickly and does well.
And I have a question. If you have the same case, like relapse of the symptoms, do you make the incision on the same place, or do you make the incision on a different place?
You know, I haven't re-operated on carpal tunnel in about 20 years. and the last time I did it, I wished I wasn't there. But if I did think that there was a reason to go back in, I'd make a very long incision and cross the wrist crease. I'd use the old incision and make a very long incision and just get it wide open. I see a question about what percentage of epinephrine in local. I use the pre-packaged stuff comes 1 to 100,000. You're kind of aiming for 1 to 200,000. So I mix it with Marcaine 1 to 1, and that dilutes it by half. So you get 1 to 200,000. Internal neurolysis is another thing that's been studied pretty carefully and shown to not make a difference. There's actually, it's been a while since these studies, but they were pretty convincing that it didn't make a difference. And then I see somebody saying their question is not answered. Let's see if we can find it. Is there a difference between two groups of patients? Yeah, I see it. Is there a difference between two groups of patients? One, the patient's paying a fee themselves, and the other paid by insurance. Well, I think what you're getting at is, if we look at the mindset aspects of health, the more agency you have for your health, your personal health, the better you do. So my example, when I was learning hand surgery in taking care of people in Boston where it was snowy, when it starts to snow, people get a snowblower machine that shoots the snow off the sidewalk, and that gets stuck. The ice clogs the machine, and and the machine gets wound up. So even if you turn the machine off, if you try to clear it with your fingers, it'll chop your fingers. So every time it snows, pretty much, people come in with crushed fingertips. And I remember two guys. One was a 50-some-year-old laborer, didn't like his job, didn't like his boss. He did terrible. The other guy was a 30-some-year-old who was self-employed and had good social support, wealthy. It's a lot of support system, self-efficacy, agency, and he did great. So I think that the mindset and the circumstances tend to be the more important thing in terms of how people do in their health. And that's why my research has gone in that direction. I still am very interested in technical things. I just think they have a lot less to offer. I think endoscopic versus open, for instance, doesn't really matter. What matters is that people can accommodate any residual symptoms they have, that they know to move after surgery and not protect themselves too much, etc.
And there's a question from Yunus Aydan. Where you locate your incision? He says, I don't enter the wrist, stays away at least 15 millimeters. Yeah,
I mean, if it's basically right here in the palm is all you need. And then you can reach up under here to get to the proximal part. So same, essentially Kaplan's cardinal line up for 1.5 centimeters to 2 centimeters. That's all you need.
Okay, thank you, sir. I think that's all the questions. Okay, thank
Great.
you for having you. It was really a pleasure to have you. You have opened our eyes for so many things.
Yeah, I hope so. I hope I've made you feel more comfortable about sort of your perspective and how it might be different than somebody else's perspective. The ways that we disagree, the reasons we disagree, and how we might come to consensus. If we can have the same language and get some more evidence, we'll probably come to the same way of doing things eventually. And it just helps us feel a little more comfortable. I hope that's what I've given you. And it's been nice to spend some time with y'all in Turkey and the surrounding countries. And I hope to see you in person someday.
Yeah, we hope to. Thank you. Thank you for having you, sir.
Thank you. See y'all later. Bye.
See you. Bye.